Welcome to the NewlyMeds podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
Just a quick note before we get started. I did have a mic issue during this recording that we did not notice until after the episode was done. So the audio does get a little rough in some spots, but there was too much good information in this episode to not share it with you guys. The issue is fixed, as you can hopefully hear. So moving forward, this shouldn't be an issue, and we do appreciate you bearing with us through this episode. But let's get into it.
What is up, everybody? And I'd like to officially welcome you to season 3, episode 1 of the NewlyMeds podcast. And really, what a journey we've had throughout season 2. Dan came aboard on a full-time basis, and we've had some really great episodes and great times shooting the content for you. We brought video to the platform, as well as a few more ways that you can get our podcast content out. We have us on TikTok, on YouTube. We've been on Instagram, but we're a little bit more active on there. And so we've really enjoyed putting together a lot of the work that we have this last season. And I know we have a lot of really great things in store. So Dan, you're back for season 3. Neither of us got fired. So I think that's all good news for the new year, right?
Absolutely. Neither one of us got fired, although after, if you're watching in video form, I am far underdressed compared to Mr. Will here, so maybe I will be getting fired after this episode.
Yeah, the letter's actually coming in the mail.
Fair enough.
So Dan, I kind of want to open season 3 up in a unique way and sort of get you on your toes thinking here. So you get dispatched to a 80-year-old female, and family says she's just not acting like herself. She's not getting out of bed and acting like really weak. And they said she's a little bit confused. On arrival, you see that she's really only identifying herself. She knows who she is, but not really making sense other than that. So she's a little bit altered. You hook her up to your monitor and maybe a little tachycardic, but nothing that's really jumping out on the screen at you. Blood pressure seems fine. Maybe a little on the softer side, but she is 80, so nothing uber concerning there as well. You feel her and she feels a little bit warm, but again, like you're kind of in this weird interim stage of like, what the heck is going on? So Dan, what the heck is going on? Why don't you fill us in on what you think right off the bat here?
Well, I think, like most everybody listening would probably be thinking, we're going to go down that infectious route. We're thinking we're looking for some type of source of infection. We're looking for some type of clue or indicator that's going to kind of confirm that hunch of an infectious EVR. I'm not going to lie, I know what the answer is going to be for this, and if you've seen the title of the episode, you probably know what it is too at this point. But I'm not going to put on a front. That's where my mind is going to go, and unless I'm seeing something out of the ordinary that's leading me somewhere else, that's where I'm going to be starting at. And I think that's why Will's itching to let you know what this actually is going to end up being and what we're going to be talking about.
Yeah, Dan. So obviously our listeners and viewers, to no surprise, this patient decompensates pretty rapidly later down the road here. They get her into the ED, most likely taking an airway. She's clinically deteriorating. And we'll say in this case, the patient ends up passing away. They do a little bit more investigating and they find out that there was an endocrine disorder. And what Dan said earlier doesn't surprise me at all, because if I didn't have the answer right in front of me, I'd also be going down that infectious disease pathway. And I think that's because even in the hospital world and the pre-hospital world, we get conditioned to these really lethal things. And sepsis is one of those things that is very lethal and needs to be caught early. But I think they sort of drop the ball and miss a few things that are also very lethal that just don't get hit hard on in EMS education. And I'm not sure why that is. And to be completely honest with you, this episode is probably going to be a little bit over my head, probably a little bit over everybody's head. But I think it's because we're just uncomfortable with the content. And it took me diving into it a little bit deeper to gain more appreciation for what actually goes on in these endocrine disorders. And I'm not exactly sure why they miss it in paramedic school. And even in my nursing education, they touched on it, but it wasn't as in depth as I think any of us in medicine really want. We always are looking for this really in depth thing, and there's just not enough time in education to do that. But this is also a fairly complex disease process. So, Dan, why don't we dive into this a little bit more? What are these endocrine emergencies, and why do you think it matters in EMS? I sort of talked a little bit about the background, but it is pretty important, I would say.
Well, yeah, obviously it is very important, and I think it matters in EMS to have this in our list of that 80-year-old female that you brought up is a key case there, that we are conditioned, as you said, to kind of go down that infectious route based on that sound, that presentation that we're hearing and seeing. The same kind of what spawned me looking into and doing some more studying in this topic, and ultimately what brought us to coming up with this episode was I had a younger gentleman, early 30s, late 20s, early 30s, no reported history, a very mild language barrier, no reported history to us. Family thought he was having a seizure. We get there and he is fighting. He is very agitated, mildly consolable by his mother. Otherwise, is non-purposefully attacking, and he's tachycardic in the 170s, 180s. He is hot. He is sweaty. Family notes that he in the past has had issues with drugs. They don't think that he's on drugs currently, but they're not 100% sure of that, and no reported history. Also, adding to that story, he went out for a walk earlier that morning and was gone for an hour or two and came back, and family hadn't seen him since he came back. And while we do everything in our power to not just automatically assume drugs, every piece of the story, everything that family was telling us, the way the patient was presenting, all of these pieces were adding up to a suspicion, excuse me, of drugs.
Hmm.
Following up with the hospital a little bit later, looking at his chart, tox screen was negative. Looking a little bit deeper, he had a history of thyroid problem.
Hmm.
Looking at his labs, which we'll talk about in a little bit, his labs were very indicative of a thyroid issue, specifically a thyroid storm, and that's also what he ultimately ended up being diagnosed with. And while not without doing my due diligence, leading into the history taking, not automatically jumping to drugs, but I had, at the end of the day, ruled that down to drugs. And again, this is another thing that if we don't have on our list of differentials, that we can very easily overlook. So, and I think that's why these topics, we're going to talk thyroid problems, adrenal problems, this kind of endocrine, all-encompassing episode, if you will, so that way we can have a better understanding in what we're looking for. But as we kind of jump into some of these disease processes, some of the pattern recognition that we want to keep in mind, and while pattern recognition is good, obviously we don't just solely rely on this, but a general rule of thumb: too fast and hot, we're thinking an excess in the thyroid; too slow and hypoventilation, we're thinking a thyroid failure; and somebody that's presenting like they're in shock and they are resistant or refractory to our treatments, we should be having an adrenal failure.
Yeah, Dan, I think that's a really good insight that you give. And one of the reasons why I was really excited that we're doing this episode is these endocrine disorders, and especially with the thyroid, they're so unique because it's one of the few things that we can diagnose or have that differential in the field without the lab work. We don't need all the gizmos and gadgets to get a good idea at what's going on. And furthermore, with that, a lot of the treatments for this pre-hospitally at least fall within the EMT's scope of practice. And when I say that, I kind of want to dive into the patho of why the BLS is so important in this. And so when we think about the actual physiology behind these endocrine disorders, there's two real drivers that are in play here. And it's something that they lack in EMS education and they definitely hit in nursing education are bodily hormones. And with this endocrine emergency stuff, it becomes really important. So the two hormones that are going to drive everything in this pathway are going to be your thyroid hormones, which are your TSH, your thyroid stimulating hormone, T3 and T4, specifically T3 and T4. And what those hormones do, they sort of set that metabolic rate for your body. So they're regulating that temperature and all those different things when your body has the metabolic kind of pathways that you go through. And with that, it's going to control the oxygen consumption that we have. It's going to rate, like I said, it regulates your temperature, and it's going to upregulate the adrenergic receptors, those beta receptors in your body. And that's going to become increasingly important as we dive a little bit deeper into some of the things we want to look for. And then the second hormone is going to be cortisol. And that's the permissive hormone for catecholamines, which something should be buzzing your head right now. When I think of catecholamines, I'm thinking of my big, huge drivers, my epinephrine and my norepinephrine that are naturally produced in the body. And so when I think about that, that cortisol is my fight or flight hormone. And we always talk about it in the sense of stress. And so that's going to maintain a lot of the vascular tone that we have in our body. It's going to support the glucogenesis that we have going on. And it's going to regulate the inflammatory response. And it's also going to control and allow our heart rate to do different things, especially if we're compensating for something or if we're clinically decompensating. And again, that's going to become pretty important as we reveal more in this episode. And so when we think about these two hormones, the thyroid hormone is going to really control how fast our system's running, that metabolic rate. And the cortisol is going to respond to how our body handles that stress. And so it's how we respond to the stress. So every time I think of cortisol, they really drilled it into us in nursing school, but it's that stress response. And I think they probably talk about it in paramedic school that we have all the increased cortisol working EMS and all that, which is true. But that's a very vitally important hormone in these processes. And so the crisis really occurs when our metabolism is too fast or too slow and that our body stops responding to that stress. And that's really important because it's something that we can diagnose just based off our assessment. Is my patient really hot? And is their heart rate so out of control for something that I would think? So to loop it back to our starting conversation, someone who's got that septic pathway, that infectious disease, that heart rate should probably be in that pathologic range of like compensatory to the infectious process. It shouldn't be anything like super crazy, maybe some tachycardia. But with these endocrine crises, we're really going to see that cortisol response kind of get all wacky. And you're going to see some pretty fast heart rates, some tachyarrhythmias that you really have to recognize are not pathologic as you would suspect to someone being septic or some sort of compensatory heart rate. They're going to be very elevated because we have that catecholamine response that's just not being regulated. And I think that's really an important concept to grasp as we talk about these emergencies because it drives how we treat them in the field. And then even now working in the hospital as a nurse in the ICU, I can see a little bit deeper pathways of the management of these patients because they're really complex because sometimes some diagnoses that we have in our head in the field, and I'm sure that providers have in the hospital, kind of sit a little higher up on the totem pole than your thyroid storm. And we got to kind of sniff it out clinically with our really good assessment skills to nail this diagnosis down. Anything that I missed there, Dan, with the patho?
Nope, I think that is a great foundation for us to start with. And kind of leading back in from where you left off, we'll start with Graves' disease. And this one is going to be the first one that we're going to talk about in which you're seeing a chronic thyroid. And what Graves' disease is it's that autoimmune disease where it's primarily surrounded by the thyroid stimulating hormone receptor. And the issue with this in this disease process is that The thyroid hormone production is autonomous and it is independent of pituitary. So we all know that our body is made up of checks and balances and that we have numerous checks in place that work together, give feedback to each other in order to make sure that we are producing enough hormones, producing enough catecholamines, whatever the substance may be. The body is always working in a feedback loop to make sure that it has what it needs. In Graves' disease, that's not the case. This THS is produced independent of any feedback system, and that's what causes this chronic thyroid excess. These patients, they are ultimately living in a hypermetabolic state. So that's why when we say if we see fast and hot, that's when we're thinking thyroid excess, because they are constantly producing more TSH and more of these thyroid hormones than what the body needs. With that, we're going to see that increased heat production and cardiac output. But with that, we're also going to see, because of the output being increased, we're going to see an increase in the myocardial demand. There's also going to be a higher glucose turnover, as well as higher oxygen consumption, especially in these patients that are not diagnosed yet and are in the early stages. And we're about to find out essentially that this patient has a thyroid condition, specific Graves' disease. But this going unchecked for so long can obviously place a strain on the cardiovascular system. And if it continues to remain unchecked, that can certainly cause chronic cardiac issues with that as well. So when we're thinking about this from an EMS stance, we have to kind of see these clinical presentations and pictures that the patient is painting for us. Maybe it is a history of some type of thyroid disease that will kind of at least set that light bulb off for us to be looking for these presentations. But Will, why don't you walk us through some of these things that we'll see with our chronic excess thyroid patient?
Yeah, Dan, I think you made a couple great points there. And some of the things that we're really going to look for, especially in EMS, and it's sort of what I alluded to earlier with the treatment, but I'll sort of progress into a little bit of the in hospital thoughts that I've seen so far in my time and some of the things that I learned about even in nursing school. But you hit on the clinical. When we get them to the hospital and start looking at the labs, they're going to have these elevated T3 and T4 levels. And they're going to have that because the TSH is suppressed in the body. And so these T3 and T4 hormones are sort of going to be high and floating all around the body. And with that, we're going to have the thyroid stimulating immunoglobulin is going to be positive. With this, you might see some hypercalcemia, which you're going to want to look for. And the liver enzymes are also going to be elevated a little bit. So something to definitely keep an eye on. As far as why this is relevant, it goes back to what I said at the very beginning of this, Dan, is so much of this in the EMS side can be treated on a BLS level. Obviously, I'm not saying if you're an EMT, cancel a medic. I think a lot of these really ill patients, like, let's keep the medic on board. And I really think, especially, Dan, you and I have had this conversation extensively. If you are in a MICU system where it is a medic and an EMT, and something comes out class 1, which, or ALS, whatever you want to call it, code 3, I think that no matter what, the medic should almost always be taking that call, unless it's like, truly circumstances allow that, this is like a BLS patient, but you're on board that truck anyway. I think that the appropriate utilization of resources should be in place for the paramedic to do that level of care if it makes sense. But in this case, I think it specifically does. We want to keep the medics on these calls, as these patients can decompensate rather quickly, that we sort of told you about in the beginning of the episode. But why do I say that EMTs can treat this really well? Well, because there's so much T3 and T4 in the body, that thyroid hormone is going to be increased, which is increasing what Dan said, our metabolic demand and the myocardial demand. So we are just chewing up oxygen. So the first thing we want to do in the EMS world, let's get them on some oxygen. And then why the medic's important is because we want to get them on the cardiac monitor. Like I said, they might be tachycardic, but the T3 is going to sensitize that myocardium to the catecholamine response. So oftentimes we're going to see these really rapid AFibs or SVTs that just they don't align or correlate clinically with a septic pathway or something of that sort of compensatory demand. And with that, these patients, if they say they have chest pain or anything like that, even with the tachycardia, if you're an EMT listening or even a medic or anybody that carries aspirin, we may want to avoid that if you're suspecting thyroid pathology, because aspirin is going to displace all that T3 and T4 binding to the proteins, which is just in turn going to increase that T3 and T4 free hormone in the body. And that thyroid toxicity that we think we're treating your cardiac chest painer for has just gotten exponentially worse. So let's use our clinical judgment here. Aspirin can fix a lot, but can't fix all. And then again, making sure we're getting IV access, because patients are going to dehydrate. Like Dan said, they're going to be increasingly hot. They're probably going to be sweating because they're so hot. And so they're just going to lose a lot of fluid to the compensatory pathways of increased temperature. So we want to make sure we can get some fluids back into them. That leads me to the ER. And so once we get to the ER, we want to make sure that we can get these hormone effects blocked before we have this increase in production. That's going to make sense in a few minutes here. So maybe we want to get some beta blockers on board, specifically propranolol. That's going to decrease the heart rate, decrease the arrhythmias, but propranolol specifically blocks that peripheral conversion of T4 to T3. If they can't have that for some reason, you're probably going to see your low pressor or metoprolol, but we want to make sure that we get those beta blockers on board. Like I said, with EMS, they're going to continue those IV fluids. And then we want to try to identify the trigger. Is it infection, trauma, surgery? Why do we think they're actually having this event of Graves' disease? And then in the ICU, as these patients progress, we want to continue that cardiac monitoring, and we want to kind of escalate what type of thyroid, anti-thyroid medications they might be on. And if we don't do that, we're going to kind of get down this pathway of worsening disease process. So Dan, you were talking about Graves' disease here. I talked a little bit about the treatments. If we don't do these things, they're going to progress towards something called thyroid storm. I have no idea what that is, Dan. Do you think you could give me some insight?
Something tells me you might be pulling my leg, but I would love to tell you about thyroid storm. So I don't think I mentioned at the top with the gentleman that I was talking about, but one of the first things I noticed about his chart when I was pulling it up was that under his medical history, he had Graves' disease. And research and studies show that Graves' disease specifically is one of the most common underlying conditions preceding a thyroid storm. And what is a thyroid storm? It is your complete hypermetabolic decompensation. It's usually going to be triggered by either some type of physiologic stressor, or it could be triggered by some type of infection, trauma, surgery, or in my gentleman's case, he was supposed to be on a thyroid medication, and he had stopped taking that an unknown period of time prior to my interaction. But there is going to be some type of trigger that leads to this. And what is thyroid storm? Ultimately, we're going to see an extreme beta adrenergic sensitivity. With that, we're going to have thermoregulatory failure. We already know that with Graves' disease, patients in a hypermetabolic state, we already have said that their myocardial oxygen demand is up and that their cardiac strain is up. And that with this thyroid storm, that's going to be increased even more significantly. There's now going to be a reduced hepatic clearance of thyroid hormone. The body's not going to be able to clear all of that free T4 and T3 that Will was talking about. With all of this, everything starts to continue to decompensate. We're going to see CNS changes with altered level of consciousness. And as this continues to progress, we can start to see full-on organ failure, or what would ultimately resemble a MODS type. So when we talk about this, when we talk about knowing these processes, we talked about Graves, and we'll talk about some of the other ones here after thyroid storm. It's not just another thing that we note on the patient chart. It's not just another thing, oh, he has Graves' disease. It's not a big deal. For the most part, if the patient is being treated appropriately and avoiding all possible stressors, sure, that's probably not a big. But life happens, and stressors happen, and triggers happen, and for whatever reason, something could potentially lead into this. So this is, this Graves' disease or Addison's or anything else that we talk about is not necessarily just an incidental finding, and that should be something that kind of throws these red flags up for us when we're looking at these types of patients.
Yeah, Dan, I think again, it's so critical to understand the why before we start talking about the interventions. So thank you for giving the detailed background on this. And now I have the pleasure of diving again a little bit deeper, which you're going to see the theme here in the episode is I'm going to touch on some of the treatments that I've researched and seen in my career and how we manage these patients in the hospital and pre-hospitally. And so when we're thinking about this thyroid storm, Dan, a lot of that clinical presentation is going to be similar to the Graves' disease, except it's going to be at this point turning into a severe life threat. So that tachycardia, that AFib, neurologically, they might be starting to have the altered mental status or even comatose at this point, having seizures. And they're going to be really hot GI. They're going to have the diarrhea, perhaps vomiting if they're still alert. They might be jaundiced because I spoke earlier with the Graves' disease that we're going to see those elevated liver enzymes. So this pathway all starts to make sense. But now, how do we manage this? And I'm going to have a little bit of a pun here. So if you hear me on it, bear with me because it's probably going to be awful. But as far as EMS goes, this is a grave thing to say, but we got to keep the patients alive. So, Dan, thanks for laughing at the joke there. But really, the management of these patients is in the EMS world, keeping them alive to suppress the hormone cascade. As soon as they begin to worsen, you're going to be managing a cardiac arrest pre-hospitally. And to be honest with you, if you have a true endocrine disaster, that thyroid storm in the field, this is way easier said than done. I mean, Dan, keeping these patients alive is just something that I'm saying, and it is not easy by any means. But how do we go about doing it? Well, we have to cool these patients. They're going to be really hot. They're going to be hyperthermic. They have that increased metabolic demand that is not an infectious pathway. So we got to cool them aggressively, which, Dan, how hard is it to cool a patient in the back of an ambulance?
It's not easy.
Yeah. So it's a key, but I understand to my pre-hospital friends, this is something that's pretty hard to do. Depending on where you're located, this is the point in my call where I'd start thinking about what resources I have. Do I have a flight crew that carries some sort of cooling blanket? Do I have a cooling blanket on my truck and something maybe more than the ice packs? How close is my nearest facility that can actually stop this hormone cascade from worsening? Like I said earlier, the oxygen demand is going to be extreme. So we need to get the oxygen on, avoiding the aspirin, same thing as before, and treating the arrhythmias. And you got to understand that they're going to be extremely sensitive to these catecholamines. So trying to have this hormone cascade controlled before we start pushing our arrest medications is going to be really vital. In the ER, this is something that I wasn't well versed in, so I had to do a little bit of research. We talked about the beta blockers earlier, and that's going to control that adrenergic response and the surge. It's going to stop those fatal arrhythmias from happening, and it's going to reduce that T4 to T3 conversion. The other medication that I was not sure what it was when I was originally researching this or how it really worked, I've heard of it, but methimazole and propylthiouracil. I totally botched that one, but PTU, and that's going to block that thyroid synthesis, that new hormone synthesis, and it's going to prevent the peripheral conversion. That's why PTU is preferred initially. And this pathway really does matter according to the research. So we want those beta blockers first and then the PTU. And then a few hours later, we want to get iodine on board to shut down that hormone release. And it has to come after the PTU, or else you're going to keep giving that thyroid fuel. That storm's going to get worse. Then we want to get the stress dose steroids on board to stop that T4 to T3 conversion as well. We want to treat that stress-induced adrenal suppression, and then finally the antibiotics. Infection's a very common trigger of the thyroid storm, but again, the infectious disease process is not the actual thyroid storm. We want to understand this. The thyroid storm is going to mimic sepsis, but it is not septic shock. And then in the ICU, we want to continue to support these patients with ventilation. We want to make sure that if they're intubated, we are managing the vent, or maybe we are intubating them because we want to prevent their respiratory system from getting extremely fatigued and hypermetabolic. We want to start those vasopressors if they're getting into that shock state. And again, we're going to want to cool these patients, whether we're using some sort of Arctic sun or some sort of cooling blanket to prevent more neurologic injury. And then again, the muscles are going to break down in this pathway. So we want to prevent that rhabdomyolysis, which for some reason is hit on pretty hard in the EMS education, I think because they don't want us to move those patients. But now we're trying to prevent it here with our thyroid storm. So as far as that emergency goes, those are the real huge treatments. Lab findings, again, in thyroid storm, you're going to see the suppressed TSH. You're going to see the T4 and T3 elevated. Your lactate's going to be elevated. We're really, really working our system hard. The bilirubin's going to be elevated. We talked about the jaundice. Glucose might be elevated. BNP, it might be elevated if the heart is really having that demand. And then if we get an ABG, you're going to see that alkalosis early, and then it might be into a mixed pathway later down the road. And so, Dan, why do we miss this, and why is it so important? Because again, the thyroid storm mimics sepsis, but if we're missing this in the field and our patients go into arrest and that cascade worsens, ultimately they might not be resuscitated. So why do we have to know what this is? Why is this so clinically important to us? Why do we not talk about it in school?
Well, I can't answer the why we did not talk about it more. I don't have an answer for that. And you kind of answered,
Dan, come on.
and you kind of answered the first question there. But we do. We have, kind of like we talked about at the top, we have these anchoring biases had drilled in our head. And for the point of sepsis, this is fantastic. But we have drilled in our head fever and tachycardia. Surely they're infectious. We see this heart rate of 170, 180, 190. And our mind goes to, oh, well, the underlying issue is the tachycardia and not something. And that process alone is what's causing me. As I said with my real world example, the agitation can lead us to anchor to an intoxication or an illicit substance. There are so many things within this pathway that can cause us to anchor down to an incorrect pathway if we are not seeing, and understanding the whole picture. And that is why it is so important for us to get the whole picture, and why it's important for us to know about these processes, because that helps us understand the big picture, right? Maybe what if I'm reviewing somebody's problem list, and I see Graves' disease and I see whatever else the normal list contains, and that Graves' disease doesn't raise a flag based on the patient, well, I'm not doing my job as well as I could and should be doing, because that could be that missing piece that would lead us to go from a sepsis train of thought to a thyroid. And I think the other thing that's important too, when we are looking at this, we're going to talk about the lab values, because it's important for us to at least have an understanding of what these patients are going to present like from a lab standpoint. I don't remember the ranges of any of these, nor do I expect Will to. He probably knows some of them just from his nursing side, and I don't expect anybody really to remember any of these. I'm sure there are plenty of people in here that do, but I don't think it's realistic for us to need to remember every single range of lab values. But when we start understanding what these lab values are measuring, that is what helps us understand what and why the patient is presenting the way that they are. And so
Yeah,
I
Dan,
think
I want to just jump in real quick. Something that I never really appreciated until nursing school was the lab values. And as we were talking about the thyroid and these emergencies, the lab values reveal a little bit more of that clinical picture. And pre-hospitally, no, it's not the most important thing. Like, you don't have to memorize these values, but it's important to understand, like, why is this one high? Why is this one going to be low? And we talk about the elevated liver enzymes. And so if they are jaundiced, maybe this disease process is pretty bad at that point. I think anyone who's jaundiced, you're starting to think that that liver is probably pretty dysfunctional. But understanding all the lab values, it really correlates and makes you a stronger provider. And I would say, too, on just a quick tidbit, we can talk about it and absolutely drop it, but I would not put off the idea that iStats are coming pre-hospitally probably pretty soon. So you're going to have to be starting to interpret some lab values sooner than you know it in the pre-hospital setting if you aren't already. So I do think it's really important, even if you're not memorizing it, but understanding that.
Yeah, at least if nothing else, from a basic metabolic panel standpoint, having, even if it's just those units that we're measuring there, is leaps and bounds beyond where we currently are. Having a good understanding of those can really help add clinical.
Absolutely. What other endocrine things can we run into, Dan, that might be on your sniffing of differentials out there in the field?
Well, I think one of the reasons that I brought up that about the lab values there is because as we'll start to see some of these, especially when we're looking at the T4 and T or TSH, we'll see an overlapping of the same TSH suppression with the elevated for T4 and T. That's going to be a pretty common theme across these different disease processes. And as you'll see, these different disease processes are vastly different. So I think it's important that we don't just look at, the lab values, or we're told the lab values. Oh, well, surely it's got to be thyroid storm because their TSH is suppressed and their T4 and their their free T4 and T3 is elevated. We'll see that you can certainly have other diagnoses just with general thyrotoxicosis that is non-thyroid storm across the board with those lab findings. And again, that's why, and I know the overplayed the patient, not the monitor, the patient, not the lab value. But it is very true because we'll see that these are going to overlap a ton. Which does bring me into my next one, which is apathetic thyroiditis. And this is just simply an event of hyperthyroidism without the warning signs. We're not going to kind of have that precursor event, that precursor trigger and stressor that's going to lead. But we are going to see this state of persistent hypermetabolism. With that, we're going to have those increased adrenergic features that we've been talking about. And this is typically going to be in our elderly population, or at least our older adults. And that's going to ultimately come down to the fact that it's going to be age-related changes in the autonomic system. Now, obviously, this is going to be a disease process that is comorbid. Typically, this is going to be in patients that have had some type of hyperthyroid issue, some type of hypermetabolism issues, but they're going to have this state of that blunted sympathetic expression due to the fact that we're going to have this increased progressive cardiac strain secondary to all of that overworking, talking. All of those increased adrenergic responses, those catecholamine, which we haven't talked a ton about yet, but those catecholamine responses, because we've had all of these continued persistent increase in these systems, we're going to continue to see that cardiac strain.
Dan, when I think about this, I think about the conversation that you and I had a bit ago with the older adults and not letting sort of the nursing home answer guide our differential diagnosis, right? Like, oh, they're in the nursing home, they're just demented or have some sort of baseline altered mental status. So when I think about this, I really go down the route of understanding what this disease process looks like before I treat it. And oftentimes it's going to look like your failure to thrive patient. It's going to look like your dementia patient. It's going to look like your dehydrated patient and maybe even your CHF or heart failure patient. However, don't let that blind you. And Dan, you and I had that conversation a while ago about not letting these comorbidities blind our field diagnosis. Like, we have to understand why these are so clinically important. But they might have the weakness or fatigue, the weight loss. They might be in an acute CHF exacerbation with this. Again, they're probably going to be in AFib, but that does not always have to be age related. It could be because of this response that they're in. Again, they probably are also going to be calm and normothermic. These patients are a little bit older and it's blunting that sympathetic response. So they're not going to be your screaming hot patient that we talked about earlier with the thyroid storm. And that's why these come on so quickly and can really, really catch you with your pants down, because you're going to miss these clinical signs and symptoms early. And the key here is that these patients decompensate so rapidly. And again, when we talk about these lab findings, very similar theme here. We're going to have that suppressed TSH with the free T4 and T3. The BNP is going to be elevated as that myocardial demand is working hard and the heart's working. They might be anemic. And again, with the hypercalcemia. We talked about what this might look like, but why is it so important to identify these? Well, in EMS, they might not have that fever. They might not have the agitation that the thyroid storm or Graves' disease would have, because that age blunts their response to it. They might have that CHF presentation, so that chronic tachycardia or the AFib, the cardiomyopathy that we think about. But again, we want to be very careful with the treatments of these patients, similar to what we talked about earlier. Keeping them stable, or as stable as we can, to get them to the ER so that we can begin that beta blockade. We want to start that a little bit slower. And Dan, I often think about the beta blockade for this pathway as the way that I would treat my AFib RVR patient that's a little bit on the elderly side. I don't want to take them from 140 to 70 in 2 minutes, right? We want to kind of get them on a slow titration and bring that heart rate and blood pressure stable and bring them down slowly. And so it's the same thing that the ER wants to do. And these patients are going to be a very low threshold for advancing them to the ICU. They decompensate so rapidly. And so then what do they do when they get to the ICU? And then I start seeing these patients in the ICU. Well, we want to manage their heart failure. We want to understand, why are they actually having this thyrotoxicosis? And then trying to stop that transition to the thyroid storm that we talked about earlier. This is another common pathway to get to the thyroid storm. So we want to make sure that we're managing them. We want to manage that thyroid hormone, because it's going to have an effect on their preload and their afterload. And so we want to get these patients in the ICU. We want to get a number of people on board and monitoring them very, very closely so that we don't progress toward that crisis. So clinically, we want to make sure that the calm appearance on the outside doesn't mean that they're metabolically stable. They might be calm. Like I said, it's going to blunt that response that their body naturally has. That aging process as we get older really does take a toll on us. And then that unexplained AFib, if you see these patients in AFib with no history of atrial fibrillation, no medications to treat atrial fibrillation on why they might have a medication for it, or an acute unexplained heart failure exacerbation. Maybe they don't have heart failure, or it sort of smells and looks like heart failure, but you don't see anything on their paperwork. Again, we want to consider that thyroid consideration. I think in these patients, Dan, it is so important to look at a medication list. Oftentimes, especially with this pathway, they may be in a nursing home, but even if they are at home, asking, hey, do you have a med list? Do you have some common medications around the house? I think in all of these patients and in all patients everywhere, it's a good habit to get into, but specifically for these endocrine disorders, we want to see what medications you're taking, because it can really, really help you narrow in your field diagnosis. And I think it takes away some of the blinding that we naturally have in the field because of the way we're conditioned. So maybe you see one of those thyroid medications and you're like, boom, I wasn't even thinking about it. But making sure you're getting hands-on to that med sheet, or the bottles that they have at their house is a huge habit that we have to get into.
Yeah, absolutely. And I think along those lines, I think failure to thrive is how, like you said at the top of this, that's how these are going to present a lot of the time. And I think failure to thrive does such a disservice to EMS for us to just kind of, it's a fallback, right? An elderly patient that is just a slow decline and we don't know why, we'll just call it failure. Even if it is truly just like the hospital diagnosis of failure to thrive, yes, people do ultimately get to a point where they fail to thrive. But what does that do to the body when we're not bringing in the fuel that the body needs? How does the body respond to that? When we start looking at these underlying processes of what is going on in that scenario versus what is going on here, we can see that there are differences in how the patient is ultimately presenting, maybe not necessarily directly to us, but what they're telling us, bringing it back to the lab conversation, to the lab value conversation, what they're telling us in their lab value. And again, no, we might not know what those are in our role in the field, but that doesn't mean that we can't continue to learn what these are. We can't follow up with these patients if we have a system in place to do so. And we can't start trying to use these clues to create a correlation between what we're seeing in the field versus what we're seeing in lab values. So I think it is important to understand that a failure to thrive patient, an altered mental status with no other explanation, we really need to be looking at. Which brings me into the next one, which is a myxedema crisis, and that is going to be a global metabolic. This is end stage hypothyroid. We've been talking about our hyperthyroidisms. Now we're getting into the hypothyroid. We're now no longer producing, our thyroid is not producing as it should be. We are in this end stage, again, a MODS type, a multi-organ dysfunction type state. A lot of these patients, we expect them to present kind of comatose, but many will not be in a comatose state necessarily on a physical outward presentation, but inside their entire inside is kind of going into a coma. And as we said, this is end stage, this is multi-organ system failure. And when we start looking at this by system, on the metabolic side, there is going to be a greatly reduced ATP production as opposed to the previous disease processes we've talked about. Now we are no longer producing heat, or at least have a greatly reduced heat generation and regulation. We're not utilizing the oxygen that our body is taking in. On the cardiovascular side, we're going to see our beta receptors have reduced activity there, leading to bradycardia, low cardiac output. We're going to have increased systemic vascular resistance. Our respiratory drive is going to start to go secondary to muscle weakness. That's going to cause progressive CO2 retention. All of that then is going to impact us on the renal side, where we're not going to be water. We're not going to be able to, all of our hepatic clearance essentially is going to be down the toilet, pun intended. On a neurological side, we're going to start seeing cerebral hypoperfusion. Everything's going to start to slow and dull. And again, this is why, if we remember at the top, when we think slow bradycardia and impacted respiratory drive, these shock-like states that are not responding to our treatments, that's when we really need to be sounding the alarm bells for something endocrine.
Yeah, Dan, I think a few of the triggers that I think of when I think of a myxedema crisis, and to my nursing students listening, this whole episode is an NCLEX heavy topic. I remember they hit this hard in school, but especially the myxedema crisis. We covered this so much, and I think they love to ask questions about it on the NCLEX because it is a high yield topic, especially in nursing. But again, I go back to looking at the medications. A few of the triggers, similar to what we talked about earlier, could be infection. Again, this is going to be the opposite extreme of your thyroid storm. So they're going to have that bradycardia. They might be more of the comatose state. So cold exposure, but also one thing that we miss all the time and we sort of write off, I feel like in EMS, is maybe this patient is on a benzo at home and they just took too much of it and now they're extremely sedated. I think that there's a lot of things that can blind us to what's actually going on. Maybe they had a recent stroke or MI, and then a huge one is the discontinuation of a thyroid replacing therapy. So maybe they stopped taking their medication, like Dan alluded to earlier, or they ran out, or it was just discontinued as a whole. Like Dan said, they may be bradycardic. They're going to have an altered mental status. Hypoventilation is common. Hypotension would be a late stage effect. They're going to have that dry skin, opposite to your patients that are extremely hot and tachycardic. Some things that I think about when we look at this with the lab findings, they're going to be a little bit opposite of your storm. So that TSH is now going to be elevated. Your T4 is going to be low. They might have a little bit of hyponatremia. Their glucose may be low because the glycogenesis is now not performing at all. They're going to have an elevated PaCO2. So we're going to think that respiratory acidosis pathway. If we're drawing an ABG in the ICU nurses, that's where we may be going with this. Their CK is going to be elevated, low cortisol, and they might have a lowered white count or a normal white count. So why is this important? And what are we going to do here? Well, it's the opposite of your storm. So not to say that every intervention is completely opposite. I'm not saying throw aspirin at this patient. So again, we want to understand what's happening clinically here. So we want to prevent that respiratory failure and compromise. And as a pre-hospital provider, this patient who's in the crisis of that hypothyroidism, I have a low threshold for intubation. We really need to protect that airway. They're going to be hypoventilatory. They're going to have CO2 retention. And so I really do want to protect their airway. I also want to passively rewarm these patients. Like I said, they're going to be cold. And I know that you're thinking, dang, this patient's really cold. Let's turn the heat on full blast in the back of the truck and put 13 blankets on them. We want to passively rewarm them. We want to keep in mind that as we rewarm these patients, if we do it too quickly, it has that vasodilatory effect, and we're going to just collapse them into a rest. They're already really sensitive. They may already be hypotensive. The last thing I want to do is create more vasodilation and put that patient into cardiac arrest. And something that my dad always likes to joke around about ever since I got into EMS are the old EMS episodes where they're like, hey, they call medical command and they have the IV established with D5W. And that was the old way of thinking. They always said it in the episodes that my dad would watch on TV when he was a kid. But that might be a good idea here. They're going to have that decreased glucogenesis. I'm not saying throw D5W at them, but maybe let's start considering some form of dextrose and replacing that sugar in their body that their brain is really starving for because they may be hypoglycemic. Once we progress them to the ER, they might give them that levothyroxine. They can give it IV if this patient is intubated or comatose. Again, they probably are going to want to give it IV because it's going to be absorbed a little bit better in the body, and we need that to restore their metabolic function. Again, we can do the stress dose steroids. We want to get those on board early. It's a lot of times these patients are going to have an adrenal insufficiency. And so giving the thyroid hormone without cortisol, we're going to put them into shock. And then again, if they are, for some reason, hyponatremic, we want to treat that. So giving them something to treat the hyponatremia and increase the ADH in the body. And as we progress to that ICU level of care, we want to make sure that, again, we are supporting their respiratory pathway. That respiratory drive is going to be suppressed. Oftentimes, I think all the time, your ICU patients are going to be often on vasopressors. That's why they are in the ICU. They're requiring that extra support. So again, treating them with vasopressors, not just for their blood pressure, but all the hemodynamics. They may be bradycardic, and we want to make sure we're giving them that appropriate therapy to improve that. And I wouldn't expect a fast turnaround on these patients. Cellular metabolism takes a bit of time to actually normalize. So being patient and treating these patients and understanding that they are going to have a little bit of prolonged recovery from this event is really critically important. So Dan, why again do we miss this in EMS, and what's the huge takeaway here? We talked about the patho, the treatment, the labs. What are we missing in the field, and why, and what do we need to do to improve this?
Oh, well, all right. So a couple things, in my opinion. First of all, I think we want, as we've already established, typically we're going to want to anchor onto sepsis or some type of infectious. We start seeing, especially when we're getting into something of this magnitude, we start seeing that normothermia or even hypothermia. And that doesn't make sense. Then we start going down, maybe it's something polypharm. Again, these are going to be for more elderly patients. Did this patient accidentally double, triple up their meds? Did they accidentally not take their meds? We start seeing some of these things, and I think we as EMS, a lot of times, if it gets to a point where we're not sure where it's at, then we kind of resort back to, and I'm not saying this is a bad thing, but we resort back to treating what we know, trying to treat symptomology wise, and well, let the hospital figure it out, right? And I'm not saying that it's, we do need to be treating symptomatic, and we do need to be doing that, but I think the key takeaway is if we understand this, we can get the ball rolling. We're already behind this once we're at this level. We're already behind the eight. And by maybe finding one of these clues, maybe finding that diagnosis of some type of hyperthyroid, or finding some type of prior thyroid or known endocrine problem, right? That can at least start us getting the ball rolling with understanding where this patient is going. And that can also, again, all of these studies, as always, the studies are going to be in the notes. But all of these studies, as with anything, and I mean, I think it's kind of a catch-all thing to say, but early recognition, early detection, and early aggressive care is morbidity. And yes, that's true across the board, but what's earlier than EMS?
Yeah, absolutely right, Dan. And I think something that I wanted to talk about with this specific pathway before we push forward a little bit, and EMS managers take the headset off or the AirPods out or stop listening at this point. Something that I think we do a really good job at in EMS when we talk about the sepsis pathway is throwing that end tidal CO2 on. And I know that maybe they're expensive, maybe we're using them too much and all the time, but Dan and I always talk about gathering as much clinical data as you can pre-hospitally. And oftentimes we're reserved with the tools that we have. We don't have the resources that a hospital has. So really that end tidal is important, and price is not relevant when I'm trying to make a field impression on these patients. But that SpO2 might be normal, but it might be masking hypercapnia because their respiratory drive is so decreased. We need to understand early that if these patients are hypercapnic, they might lose that airway really quickly. So please try to get as much clinical insight on these patients with the tools that you have. The 12 lead EKG to rule out possible polypharm, the end tidal CO2, the SpO2, whatever you have. If you have an ISTAT on your truck right now, rip a venous gas. I mean, try to get data in the field so that we can really limit our differential diagnoses and figure out what's going on here. So with that being said, Dan, what else do we have here with this adrenal insufficiency?
Well, yeah, so we kind of went down the pathway from our chronic disease process to multi-system failure on our thyroid side. So we'll jump into the adrenal side now. And the counterpart, if you will, to Graves' disease on the adrenal side would be Addison. Again, this is
Who's Addison?
we don't talk about Addison here. So with Addison's disease, that's going to be our chronic primary adrenal failure. Again, very manageable. But when we're looking at this from an EMS side, this could, number one, be that first red flag that we could see in a field patient that we're seeing, or this could be, again, with early recognition, we could be leading into a possibility that this patient has Addison. So what is this? Again, like we said, it's an adrenal insufficiency where we're going to be deficient in our cortisol levels and our aldosterone. With our cortisol, when we're deficient in that, we're going to have impaired vascular tone, impaired glucose production, and they're going to have poor stress tolerance. And on the aldosterone side, we're going to have sodium loss, and with that, we're going to have volume depletion. And so these kind of patients, we're going to be looking at that fatigue, that weakness and weight loss. With the sodium loss and the volume depletion, we're going to see these cravings for salt and salty foods, orthostatic hypotension, excuse me, with that volume depletion, because the body's not able to keep up from both a volume side as well as a vascular side. So we can start seeing that orthostatic hypotension and really, again, just kind of that fatigue due to that slow production.
Absolutely. And when we look at the lab findings, they're going to be very similar to what Dan just said. So that sodium loss and that hyperkalemia. So we're going to see the hyponatremia with the hyperkalemia. Again, we might see some hypoglycemia or a lower normal level of glucose because of this pathway. We're going to see a decreased cortisol level. And then again, we're going to see some of the kidney functionings here get elevated. So an elevated bun and creatinine and some mild metabolic acidosis. And so when we think about all of these things in the labs and the presentation, how do we treat them in EMS? Well, again, if we're thinking that there's this severe loss with the aldosterone that's creating a sodium loss and a volume collapse, let's get an IV and some fluids on board. I think that that's always a really good place to start with your patients that are showing signs of some sort of fluid loss. We want to get some dextrose on there if they're having hypoglycemia or that low normal glucose. Maybe we want to start thinking about getting some form of dextrose, whatever you carry on board. And then again, we want to get them on the 12-lead EKG. These patients might be hyperkalemic, and so that's going to lead to some very lethal arrhythmias. So let's get them on the monitor and see how progressed we are. And another episode that I would love to do a quick crit on is hyperkalemia and talking about EKG changes and really looking at that serum potassium level. You can see, are the T waves peaked and what level of potassium they have in their body, to a widened complex all the way to that sine wave on how that correlates to their serum potassium, because it does. And Dan knows if there's one thing in this world that I love, it is my 12-lead EKGs in the field. It gives you so much data and really is one of the few things we can do to gather a lot of data. So getting good at identifying things inside of those 12 leads is really important. So as we progress then toward the ER, why are we doing the things that we're doing? So we want to replace that cortisol as soon as we can. So we might give them the hydrocortisone and then continuing the IV fluids. And then again, they're probably going to progress to ICU level of care fairly quickly because the need for vasopressors. And so we want to make sure in the ED, again, getting those steroids on early, getting their volume replenished and correcting the electrolytes. Dan and I, we just talked about it. But that hyperkalemia is lethal, but any electrolyte imbalance is going to be lethal if you don't replace it or correct it or remove it. So again, we want to make sure that we are treating that. And then making sure we're protecting these patients in the way that we need to. Airway, cardiac wise, we want to make sure that we're not allowing them to enter into those lethal arrhythmias. And so we miss it, I feel like, in EMS because these symptoms are vague. And so they might, again, like all of the things in endocrine that we're talking about today, they might be masked by something else or just are a little bit too vague. And then these patients compensate pretty slowly until that stress reaction occurs, and then they decompensate fairly rapidly. So Dan, if they decompensate and get into an adrenal crisis, what is going on?
Well, I mean, you're exactly right there. And I think that is one of the most important things. Again, like we talked about with Graves and thyroid storm, we see these presentations and we see Addison's on known problem list that should really be sending spidey senses down our spine, right? Adrenal crisis is exactly what you said. Addison's disease, treatable, manageable. It's, I hate using this phrase, but it's not an issue until it becomes an issue.
Yep.
And when that becomes an issue is when there is some type of stressor, some type of physiologic stress that's going to cause a catecholamine dump. And in that time, because we know due to the cortisol that we are already kind of behind the eight ball. I know I said that earlier, but we're kind of already behind the eight ball with that. So with these adrenal crisis, it's going to be some type of acute cortisol deficiency secondary to that catechol. And with that, as we are continuing down this progressing line of worsening adrenal crisis, that catecholamine permissiveness is gone. We no longer have gluconeogenesis. Our inflammation, our inflammatory response system is going to be activated and it's going to run on. With that, because of that inflammatory response, we're going to continue to see worsening. We already had volume depletion with the Addisons, and now we're going to see continued worsening volume depletion. And with all of these things, we'll talk about with how they're presenting, but that all kind of sounds like shock to me, Will.
Yeah, Dan, it does.
I
Sorry,
caught
you
you.
caught me mid sip of the coffee there. Yeah, it sounds like shock. I mean, we might as well just treat it like that and move on, right? Well, absolutely not. So, sort of the theme today is these mimickers, but yeah, the hypotension, shock-like state, it may mask this, and so these patients are going to have a really poor response to fluid therapy, and so again, that might trigger you into some form of shock, and so you give them a little bit more volume, it doesn't work. And so now we're advancing our care. So clinically, we need to get them on vasopressors. They're going to have some sort of altered mental status, hypoglycemia, and then they may have a fever if they have some sort of precipitating illness prior to this really adrenal crisis that they're now in. So when we look at the lab values in the hospital, again, we're going to see that volume depletion, that low sodium, that high potassium, low cortisol. And then as we progress into this, we might see the ACTH being low or near normal and potassium normalizing. The important thing here is that we need to understand the key differences actually in the hormonal level. So when we think about the pituitary and the hypothalamic cause of these adrenal crises, we need to understand whether that the RAS system is intact. If it is, there's not going to be the hyperkalemia. And if it's not, that aldosterone deficiency that they're having is going to present in a different way. So what is the management like? It's similar to what we just talked about before. We're managing their blood pressure, we're regulating their glucose, and we're trying to manage that stress response. So they're going to have that cortisol dependency. A lot of times I think that these patients have some sort of steroid history, and we see these adrenal crises from these chronic steroid users. Again, it's going to be really indistinguishable from sepsis early in the pathway. So we want to just not say sepsis and move on. Try to keep it in the back of your head, looking at that steroid use, looking at some of the causes here. And then as this progresses, that secondary disease is going to lack the hyperkalemia. And pre-hospitally, again, those 12 leads are going to be really important with trying to get that field diagnosis of this. Sepsis patients probably are not going to have that severe hyperkalemia. And if this is a secondary adrenal crisis, they're not going to have it either. So we need to really be on our toes here with managing these patients and treating them in the field. So looking at patients that are shocky, but they're just not behaving appropriately. They're probably going to be refractory to your fluid therapy and probably going to have refractory hypotension to your vasoactive agents in the field. And so we need to get those higher dose pressors on board so that we're getting the cortisol to work in the body. And with all of that being said, sort of the big hitter here with all of this is the acute decompensation of these crises. And so, Dan, why don't you tell me a little bit more about Cushing system or syndrome, sorry, when we have that cortisol working, but now we're in overload, aren't we?
Yep. So we'll do the opposite end on this one now, and this one's going to be our chronic cortisol excess. Going to be hypercortisolism. This is going to be, you already kind of brought up steroid use. This is typically going to be most commonly from prolonged steroid exposure. So we're going to have the suppression of our adrenal function. We're going to have immune suppression and insulin resistance and muscle wasting. This is all going to be kind of secondary to the way that the cortisol is working in the body, right? We've talked about that at the top. I'm not going to keep repeating the same things, but with how the cortisol is working in the body, we're going to start seeing all of the side effects as a result of that chronic excess. And I think when we are thinking about this, one of the things that we need to kind of keep in mind while we are thinking about Cushing syndrome is, again, like Will said, we see these steroids and we see that these patients are chronically on these steroids. And why does this matter? Well, we're looking at this patient who has now stopped that steroid that they have been on for a very long time.
Mm.
And knowing that they have this Cushing syndrome, this withdrawal from the steroid, this can put them back into what we just talked about, as well as any other illness too. So these patients were maybe not, now after listening to this episode, right, we know that Addison's is throwing up a red flag for us, and we start seeing these presentations and we're like, well, I don't know why this patient is behaving this way. They don't have Addison's, they don't have any other type of adrenal crises or any type of adrenal deficiency on their charts, but now we see them secondary to prolonged steroid usage, and now that could also be leading us down a Cushing. So, well, what does that look like when we're first of all talking about Cushing's as a whole, and how does that kind of lead us down that?
Absolutely, Dan. And again, to the nursing students that are listening here, I can tell you from experience, because I had, I think, 2 or 3 questions on my NCLEX about Cushing's syndrome. This is another high yield NCLEX topic. So go back, listen to this episode, and do your own research. Again, these are going to be big hitters, but in the real world and not out in the NCLEX world, this is critically important. So clinical features that they talk about in nursing school is that moon face. That is going to be a clinical feature of the Cushing syndrome. They might have some central obesity. They are going to have that thinner skin, easy bruising skin. You're going to see some muscle wasting, so that muscular weakness. They might have some psychiatric changes. And a common one that I always think of that kind of clues me in is like, I keep getting infections. I keep coming back to the hospital with some infection, and they treat it, and then I get another infection and another infection. These patients are going to have frequent infections. And that's because of immunosuppression. And so when we think about these lab findings, we're going to have an elevated glucose. They might have a near normal sodium or maybe some hypernatremia. These patients are going to be hypokalemic. So we were just talking about our hyperkalemic patients. These are going to have the lower potassium. Their white count's going to be elevated, especially with some lymphopenia. They're going to have an elevated cortisol level, or at least inappropriately normal. And they're going to have a variable ACTH. As far as our EMS big picture and treatment goes, we're really treating the complications and not that excess cortisol level itself. So we're going to want to manage that hyperglycemia, because that osmosis is going to diurese the patients naturally. If we can manage the hypertension pre-hospitally, I think that's a really good idea. And then as we progress to the hospital level of care, we're going to want to try to prevent that muscle weakness with some protein fixation there. Again, better managing the hypertension and hyperglycemia, and managing that immunosuppression. We don't want these patients to get some sort of infectious pathway that's going to make this crisis even worse. As far as the big picture here that goes with this, Dan, I think that EMS-wise, these patients are, like you said, they're going to be steroid dependent. So whether they stop that, and that's why we're now having Cushing syndrome, or the abrupt withdrawal, we really have to keep that in the forefront of our patient assessment. And again, looking at those medications that the patient is on, looking at that known problem list is all going to be critically important in the field. As
Yeah.
far as, go ahead, Dan. Yeah, jump
No,
right
you're
in.
good. I was just gonna say I kind of liken this. We've all had this or many of us, I would imagine, have had this conversation with our patients when it comes to diabetes. And I know we're not talking about that right now, but we have this conversation. The patient is concerned about their elevated blood glucose when they have an infection or they're taking medication or they're currently sick or just recovering from some type of benign illness, right? And we have this conversation. Well, you're sick, the body it kind of wreaks havoc on everything within the body. And I kind of liken that to this in the sense that when we are dealing with an adrenal suppressed patient, any acute illness can kind of do the same thing that we talk to our diabetes patients about.
Yeah.
When we have an adrenal suppressed patient, any type of acute illness can do the same to them. And I think that's important when we are not only educating ourselves and educating our patients to keep that in mind, but to make sure that we are, again, having this in our back pocket, having all of these different processes in our back pocket, and at least having a general understanding of how each one is working and how each one is different from the other. Again, we are not going to be in the field, we're not going to be the ones coming up with the patient's long-term care and those types of things. I think I have 6, 7, 8 studies listed here for you guys to take a look at, and each one of them in some capacity, as does every study, early recognition, early detection, aggressive treatment. If you are listening and you're a field provider, that starts with us.
Yeah. Yeah. We're the earliest intervention in these, Dan. And so I think for me, some of the big picture takeaways that I have from this episode are to go back and reevaluate some of the education you received in school. Look at those hormones and what they do. I'm not saying memorize levels, but just have a little bit more of an understanding. So remember that thyroid hormone is going to control our metabolic rate. Our cortisol is our fight or flight. That's our stress. So we're going to maintain our blood pressure, our glucose, and our actual stress response with that. Aldosterone is going to control the volume and the potassium. And that's where you're going to start to see some of that fluid and electrolyte shifting. And what Dan just said, I think, is the most important thing that I have to say here. These endocrine emergencies fail silently at first. And as they progress, it's catastrophic. And sort of the asterisk I want to put on that is, yes, they're harder to identify at first, but I think we just miss the diagnosis in the pre-hospital setting, and we are the earliest form, right? So like Dan just said, if we're not identifying these endocrine emergencies early, or at least having that inkling of thought in our head that might be one of the long list of endocrine emergencies we just talked to you about, we have to keep that in the forefront. Even if we're thinking sepsis, do not let it blind you. And having that early recognition, because these patients will decompensate so quickly and so catastrophically to a point to where resuscitation might not be even feasible if we are too late pre-hospitally or not trying to get these patients to the appropriate resources that they need to recover from the crises. So Dan, what do you have? Any tidbits of pattern recognition for EMS? Any tips that you want to give the providers that are listening and made it this far in the episode that they should take away from this episode?
We started off with it, and I want to end with the same exact thought process. Now that we've actually talked about them, hopefully this will kind of make sense and stick a little bit more. Thyroid excess is too fast, too hot. Thyroid failure, too slow. Hypoventilation, altered mental status in late stages. And that Shocky patient that we can't figure out why they're not responding to our treatments, shocks that's refractory to our normal treatment, we should be taking adrenal. And I think if we have at least that general thought process when we're looking at these patients, when we otherwise would be like, I'm not entirely sure what's going on here, I think those can give us, those 3 points right there can at least give us a good jumping off point. and kind of steer our thought process in a different way.
Absolutely. Well, Dan, we kind of opened up the new year pretty strong here with this episode. And so I want to thank all the people that are watching and listening for sticking it out this far. I know for me, I had my show notes up and I still kind of get these confused. I would urge you to go back in, look at the hormones, look at the recognition, because this is really, really important that we get right in the field and also get right as we progress into the hospital and that care is taken to a higher level than we can provide in the pre-hospital environment. But it can definitely get confusing. So I want to thank you for listening. I hope you guys had a great new year. And Dan, I know I am stoked. If this is episode 1, I'm really excited. I know what we have in store down the road. But I think we really have a great season coming up here for the NewlyMeds. So thanks to all of you. Any last bit of takeaway from you, Dan?
Nope, I would just echo exactly what you said. I too share your excitement for what is coming. We did start off strong, and we're going to continue strong with what I believe is going to be a lot of good information for a lot of people that are listening to this. And so I'm excited to continue both our journey together, Will, as well as our journey with the community that we're building up here. I think there's so much power in knowledge and in learning and in growing together. And I'm excited to be able to do that with you guys. And I think just because we are the ones here talking doesn't mean that we're not still learning as we're going along the way as well. These exactly what Will said, we're gonna dive into some topics that I'm excited to dive into because that is just yet another refresher for me and to kind of build up my background in that. Well, yeah.
Absolutely. This has really been great. And I know Dan and I learned so much from each other, but we learn even more from you when you engage with our episodes, commenting and DMing us, emailing us, letting us know the takeaways and insights that you have. It's making all of us stronger in this community together as providers. So thank you so much. At least for me, I can't wait to jump into the next episode. So we'll see you then. And if Dan doesn't have anything else,
That's it.
we'll catch you on the next one.